Okay, that's the biggest myth ever. Welcome back. We're gonna watch the 7th episode of season 1 of The Pitt. My name is Peggy. I'm an emergency medicine physician, and this is my husband.
James, internal medicine. Everyone's gonna have moved on to Squid Games by now.
James, are you sleepy though? Everyone really wants to see sleepy James.
Pretty sleepy.
Okay.
I also have a cold, so you're gonna have some coughs this episode.
Thank you for following along. If you're still watching this, we're trying to get through this whole season. And if you want to find me on social media, here's my information. I'm on Instagram and TikTok. Let's just get right into it, right?
Mm-hmm.
All right, episode 7. Here we go.
Elle, you're making a scene. I'm so sorry about all of this.
Daughter locked herself in. Sister started fighting. Colin's got in the middle. Mom pushed her.
Pretty sure security has access to all the bathrooms for emergencies in the hospital.
At one of the hospitals I work at, the bathrooms don't lock for this reason.
Yeah, security wouldn't barge in, but if they had to, they could get in.
I've got 4 patients waiting on ICU that have been here since before I got here, and it's already 1 o'clock.
I can see that
Got
you're...
4 more waiting on psych. One of them's been here for a fucking week, so please, for the love of God, hire more nurses.
I'll come back later.
That's not gonna help anything.
Do you think it's just a nursing issue?
No, it's this is a lot of issues, but I remember during COVID it was a nursing issue. That was the main thing because they had beds open, but there weren't enough.
Right. There's physical beds, but they couldn't open them as spaces because there's no staff.
Yeah, because
no
there's a
nursing.
required amount of nurses per bed. I don't think that's always the issue. I think that is done now for most hospitals that I've seen, but I mean, it's all sorts of things. There's not enough beds available. There's only, most hospitals only have 12 or 24 or however many ICU beds.
So you're saying it's also a physical bed space issue?
Yeah, I think most of the time it's a physical bed space issue, but during COVID especially, there was a huge nursing issue. But there's all sorts of factors.
I mean, I will say even now, like this week when I work overnights, there'll be lots of bed spaces but less staff.
Oh, overnight? Yeah.
Well, not just overnights, but like I'm just applying this to overnights, but it still happens now that we have not enough staff, at least in the ER.
Yeah, we'll see that.
Having metal detectors in the emergency room, very important. Not every emergency room that I work at has those, but most of the emergency rooms that I worked at have had metal detectors.
Yeah, I mean the psych thing is like, there's just like nowhere to put psych patients. Where do you put a psych patient? You don't admit them all.
Yeah.
There's not enough facilities for them since like the
And
70s.
if the psych facility doesn't have enough space too, that's the problem. So they need more psych facilities too.
Yeah, exactly.
Yeah.
And then there's all these pushes to get rid of psych facility. This is a big political thing, but there's all sorts of reasons. But psych is a huge issue in terms of placement because there's no good solution.
Hey, pussycat.
So scary.
My name is Whitaker.
Pussycat, I need to use the bathroom. Can you get a key for this?
You need a bedpan, Myrna?
Bless it.
Good sandwich?
Yeah, really good, actually.
Yeah, I can tell from all the crumbs you're getting on my workstation. We eat in the lounge, if we eat lunch at all.
Okay, that is a total lie. He said we eat in the lounge.
Yeah, that's not true.
Okay, that's the biggest myth ever. We eat at our workstation all the time because if we
Are you trying to get Jaco to shut down your hospital?
Okay.
God, last
Jaco, avert your
Last
eyes.
time Jacob came
Earmuffs.
by, I had to throw away a perfectly good cup of coffee because it was at the nursing station.
Oh yeah, they throw away lots of food and drinks, but the point is rules and real life, very different. Like yes, technically you shouldn't be eating at workstations and stuff.
It's a huge patient safety hazard.
Right, because people die when we eat at a sandwich at our computer station. But anyway, like if we weren't allowed to eat there, I mean, let's put it this way. If I didn't in real life eat close to where I work, I would never get to eat. And if someone really sick were to come in, I wouldn't see them when they come in. So in the emergency room, we don't always get to go to the lounge to eat. I think like it might be different for like people that have scheduled breaks, like nurses that have mandated scheduled breaks. They can physically leave and then come back. The med students, the residents, and the attending doctors, we do not have any mandated breaks. And you eat whenever and wherever you can, because if you had to go away to do it, it may never happen.
Yeah. Yeah. Although to be fair, most other places in the hospital, people don't eat at the nursing station. Coffees, drinks, yes, like water, but not eating. So.
I don't like
But
to
in
eat
the
at,
ER, it's
I don't like to eat
different.
at the station. Trust me, I don't like it. But sometimes like I have to be like nearby and stuff like that, or like it's just like I'm starving and there's like I'm still doing stuff, so you have no choice. He was like, if we only eat in the lounge. I was like, ha ha ha. Like thinking about all of my residency years and how we just ate right there.
I think med students do eat in the lounge.
Yes, if you're a med student, you're not really necessary to patient care because we can still run it without the med student there. So please go take a break. But the attending or the resident, yeah, right.
Any update on my abandoned senior Ginger? I just hope she comes back. Sometimes I occasionally jump to the worst case scenario, so I...
Understandable given what we see here. I'll let you know if I hear from Rita.
Okay, thank you.
Well, earlier she was saying, I'm sorry, I came to the worst conclusion to the social worker. And the social worker's like, that's understandable given like what we see. And that is 100% true for me.
Oh,
right?
yeah. Oh, I think that's normal. I mean, I think most doctors, period, get very jaded very fast about life.
Oh, no, but like I'm even talking about like my personal fears. For always like worst case scenario.
Oh, yeah.
Yeah. I think it's because I think I only see emergencies, I see freak accidents, I see tragedies. And so in emergency medicine, and especially we're drilled in during training to think worst first. They literally tell us as residents, when you think of the patients, to think worst first because of the diagnoses that they might have. Our job is not to find what's the most common or more likely, but is to also rule out what could be the worst possibilities of what they're experiencing. So you might have chest pain. Like it might be more common to have chest pain due to, musculoskeletal pain or whatever. But what's the worst possible cause of chest pain would be maybe a heart attack, maybe your aorta is dissecting or tearing, and a dissection is super rare. But I mean, we have to think about it more often than it actually happens. And that's what makes a good emergency medicine physician, because if you really only thought of the more common things and stuff, then you would miss the rare ones. So anyway, I'm trained to think about the worst and rare things happening. And so in my own personal life, that happens a lot, unfortunately. So we tend to be very risk of, at least there are the extreme, the thrill seeker emergency medicine physicians, right? The ones that love the adrenaline, going rock climbing, they're going scuba diving.
Motorcycles.
They're riding the motorcycles, even though we know that motorcycles are super dangerous and we call them donor cycles. But then there's me, and I'm just like, oh my gosh, swimming pool must put up all the barriers so that no child drown. I've got locks on all of the things, all my medicines are all locked away. I'm just super paranoid that something dangerous will happen, or someone is gonna choke on something if I don't cut it in half into tiny little pieces. So
yeah.
That's me.
Saw her in the road. She was in and out of the intersection yelling at cars and people. What's her name? Nandi. She's my roommate. Does she have a psychiatric condition? Not that I know of. Get her to bed. You're okay. Let me go!
Acute psychotic episode?
Hi, Terrence.
Yeah, that's unfortunate.
Mania could be.
Hello?
Or
What was that?
It's olanzapine, 10 milligrams.
Do you know any of her medical history?
No, we've only known each other for a few months. We're both influencers. We met online. I thought it would be a good idea to live together.
When did she start behaving differently?
About a month ago. She's been up at all hours talking to herself nonstop.
You called it.
Okay, differential diagnosis.
Schizophrenia, first psychotic break. She's in the right age range.
Yeah, what else?
The drugs also common in this age group.
Endocrine, hyperthyroid, infectious encephalitis.
Those are all possibilities.
Could be the anti-NDMA encephalitis.
Encephalitis, yeah. I mean, it could be any encephalitis.
But that's we learned about that during med school, and they didn't know about that even 10 years prior.
Yeah. I think they knew about it, just didn't know how prevalent it was. But it's one of the only reversible ones. That's why it's gaining so much traction right now.
Harvey, if we get you up to cardiology, they can open your blocked artery. We can stop this heart attack. VFib. Whitaker, chest compressions. Charge you 200.
Chest compressions? Did you just code?
Yeah, I was like, he literally just coded as he put on the paddles.
Still VFib. Resume compressions. Let's get him on the Lucas.
Oh my god, this guy just had a cardiac arrest.
Literally, split second. I see he's getting chest compressions.
He's taking progesterone?
I put it in his coffee every morning.
What?
His libido would stop.
Stop what?
I think he's molesting our daughter.
Oh my god, this is
That is so
heavy.
dark.
Oh my gosh.
Super dark.
It's horrible.
Here we go.
EVG.
Looks good.
Let's do this.
I accessed the right femoral vein.
Thanks for that.
So Whitaker,
You can put an
this
ECMO
like a
during the
sterile
VFib arrest.
Can't introduce bacteria.
They've done that at my residency hospital.
Really?
Yeah, I mean, I've never been there for it.
Flows into the ECMO machine for oxygen and gets pumped back through a second hose into the left femoral artery.
These guys are impressive.
The ECMO does all the work of the heart and lungs.
So that's ECMO.
Yeah.
You can
VA
explain
ECMO.
it. I think you know much better than I do.
There's different kinds, but essentially it's a little device that oxygenates the blood and also circulates at the same time. So it basically provides a certain amount of circulation with there's different kinds. It can either replace your lung function or your cardiac function to a certain extent. It's not perfect. They use it a lot for patients who are either so ill that even if you're on a ventilator, you're still not getting enough oxygen. They can give you oxygen that way, or if you have extremely low severe cardiac disease, then they can essentially replace the function of the heart, including oxygenation, temporarily. It's not meant to be long term. They use it in a lot of, transplant potential patients.
How long can you be on ECMO for? Days?
Oh, longer. You can be on ECMO for like weeks. I mean, I don't think that's what it's really intended to be.
Yeah.
But it's been done for long periods of time, especially lung replacement ECMO. Cardiac ECMO, VA ECMO, I'm not sure how long you can really, because it's not meant to be like a long term. There's other cardiac assist devices that are meant, so I don't think you can really be on it for that long. But that's pretty advanced cardiology stuff.
It's all cardiology, right? It's not like surgery that does it ever. It's all interventional cardiology.
It's usually done by a cardiothoracic team. They're the ones.
CT surgery?
Usually CT surgery is the one who does it, and depending on whether it's VA ECMO, if it's lung ECMO, or if it's cardiac ECMO.
Interesting.
It's called VV versus VA for anyone who's interested, but but either way, it's usually run by an ICU team, and usually it's cardiothoracic surgeon who does it, in my experience, but I'm not sure. I'm sure there's different practices across the country.
It's people, not me, emergency medicine, so that's why they called the ECMO team. But anyway, I guess for this patient, he's in cardiac arrest from, I guess they're saying it's a heart attack that's causing him to have a dangerous arrhythmia, ventricular tachycardia or ventricular fibrillation, VFib, and they keep shocking him, but it's not shocking his heart out of the rhythm, so they're doing that ECMO then to, I guess, support the heart, or not like bypass the heart, but like support the heart.
Yeah, I mean, again, I've only seen maybe 2 or 3 ECMO cases in my entire life.
Rare.
It's very rare.
And only specialized hospitals do it.
Yeah, very, very tertiary hospitals do it. It's really like the very, very, very like last ditch effort. I didn't even know you could do it during an acute heart attack where the heart's in cardiac arrest. Like that's not usually something that. That said, I mean, usually it's very rare in the hospitals that I've worked at that you just have an ECMO team. Even when I worked at university hospitals, it's not like the ECMO team is just like ready to go any second. But I haven't worked at like a major academic center for a while. So usually like they have to get the ECMO team there, and if you're in the middle of a cardiac arrest, you don't have like an hour or 2 or 3 hours to wait for an ECMO team. You've got to get it done like immediately. So I guess it's feasible if the ECMO team's literally like 2 minutes away.
But you have to be at an ECMO center. That's the
you have to be like literally
problem.
be having a heart attack at the ECMO center.
Yeah, ECMO centers are few.
They're super few.
Very few. Majority of hospitals in our country are not ECMO because they're regular community hospitals, and so if you have something unstable or die from something that ECMO could potentially treat, but you're at a place that doesn't have it, then you're just kind of out of luck, right?
Yeah. I mean, I didn't know that you could do ECMO for a STEMI in the middle of a VFib arrest.
Have you seen them do they were doing the 2 defibrillator pads and 2 shocks? Have you seen
that? Yeah.
Yeah, we'd like to do that. So, you see on the movies like, clear shock, and it's with those like big metal things, but I've never used that ever. I've never seen it. We just do the sticker pads, and it's like automatically shocks them. And so that's realistic. And then in cases of refractory, like ventricular arrhythmias, like where it keeps not working with the one set of pads, then the latest thing is doing 2 sets of pads, 2 sets of 2,
Mhm.
and then using 2 separate machines, and the 2 people have to be like 3, 2, 1 shock at the same time.
Mhm.
Yeah, and it has worked.
Dr. Robbie?
Yep.
Lab's all good on our influenza patient. Tox screen negative, head CT normal.
Head CT.
She had memory problems, tremors. I had a hunch.
Well, she's had $1 million workup now, so I can't refuse her.
But-
being a good doctor, Dr. Mohan, is knowing when to dig deep and knowing when to move on.
Wait, he's grilling her for ordering a head CT on
I would
her?
have ordered a CT.
Yeah, I think it's totally appropriate that he did that.
Yeah, I
For
agree.
a first-time presentation of mental status, possible psychosis, it's really
Yeah.
important to get a head CT.
Yep, agreed. Yeah, those tox screen and CT head isn't exactly $1 million workup. It's like $1,000 workup.
She's been cleared for psych, but she keeps saying something's wrong. It doesn't feel right to me.
Listen to your patient. Trust your gut. I'll back you up.
Did they check the thyroid level and everything too?
There's no fracture. So
They must. They should have, because they even brought it up a couple times.
fully healed.
I'm not crazy.
You have to believe me.
Do you use products from other countries?
Some of the best stuff is from overseas. They have better products for
What kind of toxicity is this? Organophosphate?
removing wrinkles.
You don't have wrinkles.
He'll be here before you know it. Don't do that. You have to watch your levels.
Do you have photos of these products?
I mean, it could be like a heavy metal toxicity, but I don't know what kind of heavy metal leaches
Lead?
through the skin.
Lead toxicity?
Does it go through the skin?
I don't know.
But that would have shown up in the labs, like at least some anemia or something.
I'm thinking this is a toxicology case.
Everything is pointing to new onset schizophrenia. So what zebra are you hunting?
She's been using a face cream from Asia with a high mercury content. This could explain all her symptoms.
Mercury.
Oh, mercury poisoning.
Oh, yes.
Mad as a hatter.
Mad as a hatcher.
Yeah.
Yeah.
I've ordered a heavy metal panel looking for mercury, lead, or arsenic.
Why didn't you consult me?
I thought you were having a bad day.
Ooh. Don't say that to me. I don't think he should scold her for doing more
No.
testing, though, honestly. Like,
No, I think it's fine.
I think it's best for the patient, obviously, and she's
Yeah.
thinking about important things. I would encourage the resident to do that.
Yeah. Well, she's not a resident, but still, that's.
She is a resident.
Oh, she's a resident?
Yeah.
Oh, okay.
Although it would slow things down, I would just say admit the patient, and then they can do that stuff.
Right. Does mercury go through the skin? That was inhaled.
It could, because that's why the Mad as a Hatter, they used to put mercury in the hats, and then the people, the hatters, would get mad.
I thought it was from the fumes from.
I don't know. You can look it up.
Yeah, we should look it up.
Your husband is going to be admitted to the ICU, and if everything goes well, then we'll extubate him and the chest tube can come out. But he's going to need to stay in the hospital for 3 or 4 days.
Wait, I never tell patients how long they're going to be in the hospital.
Yeah, you can't know that.
What you did to your husband was against the law. So unfortunately, we're required to report it to the police. Hopefully now that it's out in the open, she'll take the necessary steps to handle this the right way.
They want the mom to report the sexual abuse, is what they're saying?
Yeah, I mean, I'm sure it is very difficult, but to be fair, the proper thing to do probably would have been to talk to the police or somebody before poisoning your husband.
No, I'm not saying she should poison her husband, right?
Right, like she
So-
should probably, I don't know.
Right.
I'm sure that's difficult. It's not like I've ever been in that situation, so.
I've
but-
never had that situation that I was aware of, but that was pretty dark.
Yeah, it's
I
pretty
wouldn't know
dark.
how to navigate that. I would ask social worker for sure.
Yeah, but probably those steps first, and then poison.
Friendly massage becomes a hand under your shirt, and then fingers inside you, and it's all our little secret, all because you love us so fucking much.
Oh, she's like triggered with it.
Yeah.
She has experience.
You are never going to touch your daughter again. Twice if you agree to this. Once if you want me to let you die. I've already lost 2 patients today. 1 more's not gonna make a difference.
Wow, was that the super dark thing that everyone's like, oh, wait till you see this?
I think there's a lot of dark things that happen in the show.
This is the darkest one so far.
That was weird.
Yeah.
I mean, I don't agree with like threatening our patients.
Well, that was clearly a TV show thing.
Yeah.
That I don't know.
I don't want people to think that that show is completely realistic and this is like, you know what I mean?
Oh, yeah. No.
Yeah.
I think people are smart enough to know that.
Well, anyway.
There's a Batman vigilante in every ER.
Well, let's put it this way. We have to take care of all types of people in the emergency room.
Oh yeah.
Some of who are victims and some of who are perpetrators of acts of terrible things. For example, you can have an attacker that gets injured as well and come into the emergency room, right? And we have to take care of these people. So I just try to turn off that side of like the outside, you know, what's going on, and just focus on like treating this person as a human. Just treat this person like I would treat any other patient.
Yep.
It's the only way to get through it. We take care of patients that come from everywhere, and also like we also take care of patients that are like incarcerated in like custody, like with law enforcement. So, you know, regardless of what happened, what they did or didn't do, like we have to treat all patients with decency and with respect, even if they may not have done that to other people. But I guess it's sometimes easier said than done, though. If someone were to tell me, hey, by the way, did you know this patient does this or whatever, like that would be very hard. So I prefer to know less, actually, in a way.
Yeah.
It's better to know less and to not ask questions, because I want to be able to give unbiased, full, like good care to patients.
Yeah.
So that I mean, if someone told me this about my patient, that would it'd be hard to not be biased.
Oh yeah.
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 But I mean, and also like the fact that he could hear her when he was intubated was kind of weird.
Yeah, I mean, he should have been more sedated.
Yeah, usually when you have a breathing tube in your throat, like you're induced into a medical coma, like you're on full sedation, because if you're awake and able to understand and blink and stuff, it's really hard to tolerate that tube in your throat. You're like bucking, you're fighting, it's like hurting you, it's like gagging you. So usually people are not just calm and like looking at you and like blinking and stuff.
Yeah.
Yeah, so that was kind of not accurate. Oh, she's taking.
Prestone. That is going to be one long drive back to Tennessee.
Whoa, from Tennessee all the way to Pittsburgh?
That was really far.
That's really far.
She's about to throw up.
I think she's in pain.
How far along is she?
Very early, first trimester.
Oh no, it's not a good sign. Yeah, you can take this one. Wow, this is a really dark episode. Damn.
That's sad. I don't think this is right, I will say, but I will say it is more common than not that women working in healthcare, women physicians, have experienced miscarriages literally while at work and still work. I personally know people like that. I've heard many stories of people like that, and or even they're experiencing their miscarriage at work and they have to carry on, or they just had their miscarriage or procedure to clean out the womb from a miscarriage or something like that, and they have to go back to work the next day, because being a woman in healthcare is really hard. Being a physician, and I don't know if like us as physicians are hard on ourselves, but they just, we just think, okay, we just have to carry on and act like, do our job and stuff. But it's hard. I mean, I don't think it's necessarily right. I think women should be able to put themselves first, take time off, go home if this happens to you on a shift. But is this lady going to go home? I bet you she will continue with her shift.
Oh, yeah.
Yeah. And I don't think that's necessarily right, but that's what most of us would do. And it's really sad. And yeah, seeing that made me like really, really sad. And it's hard to watch. But I bet you she's going to continue her shift.
Yeah. Oh, for sure.
And there's countless stories, I would say, because miscarriages are actually very common. I mean, I have to counsel patients on miscarriages all the time, because patients come into the emergency room and have to give them news. So we counsel patients on miscarriages and how common they are. And think about that and the number of women that are working in healthcare, nurses or doctors or techs or whatever, but I'm just speaking about physicians myself. And the number of us that have had miscarriages and continue to work, or have just go straight back to work and don't take time off, it's sad. And I wish there was a little bit more protection. This is not even to talk about like pregnancy and postpartum like rights and stuff, because in our country in America it was just like horrible maternity leave. So getting into that, like it's just like women's health and putting our bodies first. It's just, there's a lot to be improved upon. So it's sad, it's hard to do. Thanks for watching, guys. You're like, wow,
more
this
than
is gonna
halfway.
get dark. More than halfway. Episode 8 is gonna be hard.
Oh, really?
Yeah.
Oh, damn. Okay.
Yeah.
Nothing like a depressing show.
Nothing like a good dramatic show. I mean, that's the whole point of the show, right? It's not supposed to be like an uplifting show.
Yeah.
It's supposed to show you how dark and heavy it gets, and it It's starting to get there. I mean, it wasn't already like that when people died in the first couple of episodes.
I don't know. It's different. Because I'm used to people dying from medical diseases.
Yeah, I mean, that's the thing is like we have to recognize like we can't save everyone. Early in our careers, we might take it harder, but later on, we just kind of, most patients that pass away, we have to be like at peace with that we did the best we could, and we cannot save everyone when it's their time to go. But I will say the harder ones are the ones that come in talking to you. They're like, hi, I'm having this, or blah, blah, blah. You like get to see them, you talk to them, and then they pass away, they have a cardiac arrest. Those are the ones that really stick to me because they're like personable, you know, you met them. So those are really hard.
Yeah.
And that poor student already has 2 of them.
Yeah.
If you have anything, comments, love to read them below. Questions, give me your insights, what it's been like for you watching the show, or if you're working in healthcare. And thanks so much for following along. I hope his cough gets better.
Die.
All right.